Hi, everyone. Thank you for coming. So now it's my huge pleasure to announce Dr. Narayan. He received his medical degree in India and completed residencies in internal medicine at the Postgraduate Institute of Medical Education and Research in India and at Cook County Hospital, Chicago, Illinois. He completed clinical fellowships in nephrology at the University of Illinois College of Medicine at Chicago, Illinois, and University of Texas Southwestern Medical Center in Dallas, Texas. He is board certified in internal medicine, nephrology, geriatric medicine, and is a certified specialist in hypertension by the American Society of Hypertension. Dr. Narayan is a clinical associate professor of medicine at the Texas A&M Health Sciences Center, College of Medicine, and Baylor Scott White Healthcare in Temple, Texas. He serves as the medical director of the Abdominal Transplant Program and medical director of the BSWHK Killeen Dialysis Facilities. His clinical practice focuses on all aspects of nephrology as well as kidney and pancreas transplantation. So welcome, Dr. Narayan.
Good morning. So hope all of you are having a good conference. I certainly didn't expect this cold weather coming from Texas, I can tell you that. So Sherry, thank you for that kind introduction, and I'd also like to thank the CAP and the NKF for inviting me to present this year. So your course is entitled Mastering the Dialysis Prescription. What I thought I would do is to show you some examples of where your dialysis prescription, most of you I'm sure know how to write a dialysis prescription, but I thought certain things that I could emphasize, some scenarios that could occur in the dialysis unit that would be of benefit. So my objectives for this talk is to help you tailor the dialysis prescription to address, as I had mentioned, some complex clinical scenarios in dialysis patients, and also to make sure that those patients are doing well by early recognition and by addressing the changes in their clinical status. So all of you know that there's a very high comorbidity in dialysis patients, right? Many of them have multiple medical issues, and the dialysis procedure is also complex. But it's remarkable that despite that, there's very little in the way of emergencies in hemodialysis. So in this slide, you can see the incidence of these complications. These are per million dialysis sessions. So if you look at it, there are about roughly 450,000 dialysis patients in the US. You multiply that by 156, like the number of sessions in a year. So if you do the math, that comes to about 73 million dialysis sessions. So given that, it's remarkable how small the amount of these things occur. I mean, you don't see a number, it's because they're either underreported or not reported. Okay, let's start off with a case. So this is a 76-year-old African-American female with hypertension and ESRD on in-center hemodialysis, and she also has a past history of schizophrenia. She's sent from the nursing home for evaluation of hyperkalemia. She had missed dialysis for 3 weeks due to a dysfunctional AV fistula. So on presentation, she was at her baseline mental status. Her lab values were significant for a potassium of 6.8 without any EKG changes. Her bicarb was 10, BUN 229, creatinine 18. She was given insulin and dextrose in the ED to help her potassium, and a central venous catheter was placed for dialysis. So immediately following the dialysis procedure, the patient was noted to have twitching of her extremities and became unresponsive to verbal or painful stimuli. Her blood pressure, heart rate, and oxygen saturation were within normal limits. Her CT, MRI, brain, and EEG were also unremarkable. The patient slowly came around, started responding to painful stimuli in about 1 to 2 hours, and was back to her baseline in 6 to 8 hours. So off note, the patient's labs that were drawn post-dialysis showed a dramatic drop in the BUN pre-dialysis from 229 down to 106. Does anybody know what the diagnosis here is? That's right, it's dialysis disequilibrium. So dialysis disequilibrium is currently not a common syndrome, but it's important because it can still occur in certain situations. It's described in dialysis patients. It is characterized by neurologic symptoms that can be of varying severity, and it's primarily due to cerebral edema. So it's unclear if it occurs in patients with AKI or advanced CKD, and it's also unclear if there is a set urea nitrogen value above which it occurs. So typically patients who are affected are new dialysis patients with very severe azotemia, so very high urea nitrogen, or patients who have skipped dialysis sessions, like multiple, 3, 4, as in our patient, who have a very high urea nitrogen, and then you dialyze them and bring that urea nitrogen down very rapidly. The other factors that can predisposed to this condition are the concomitant presence of severe acidosis, older age or younger patients, the presence of hyponatremia, liver disease, hypertensive emergency, and also if the patient has any other underlying neurologic disease. So if you do a CT scan on these patients, this is what you will see. You will see that there is overall loss of the basal cisterns and loss of the gray and white matter differentiation and just overall global hypoxic changes. Now, granted, this is a severe case of dialysis disequilibrium, but at autopsy, you will see that there's a lot of congestion in the brain, and there's a very flat gyri, and the sulci are very narrow. So why does dialysis disequilibrium occur? Well, there's 3 theories of pathogenesis, but really only one of them has really been truly accepted, and that's called the reverse osmosis theory. So let me explain to you how that occurs. So this is your normal state, the blood-brain barrier, your CSF, and your plasma. Now, urea has a reflection coefficient of 0.44 to 0.59, and it doesn't really go across the membrane without specific transporters called UFB1. So the urea needs UFB1 to go freely across the membrane between plasma and CSF. And so this allows your maintaining your brain cells and ECF to be the same osmolality. Now, in uremia, what happens is there is a downregulation of this UFB1 transporter such that urea now cannot go freely across the membrane. And because urea cannot go freely across the membrane, there's a lot more urea molecules that are stuck within the CSF. And then now, when you do dialysis and drop the osmolality from a higher 320 down to 290, you cause water to go across the membrane into the CSF, causing the cerebral edema. So this is why it's called reverse osmosis, because osmosis means moving the solute moving from an area of higher concentration to a lower concentration. But here it's water that's moving across to help equilibrate the concentration. So that's why you get this cerebral edema, is because water freely goes across, and it's actually upregulated. The water goes through the aquaporin channels. So the other theories, which is the acidosis theory, is basically that when you have intracerebral acidosis and you use a bicarbonate dialysate, you cause lots of carbon dioxide, and that gets converted with carbonic anhydrase and release of sodium and potassium ions, and that further lends itself to the cerebral edema. Not so much accepted. And then there's a third theory, which is the idiogenic osmoles. So how does that present, dialysis disequilibrium? Typically, most patients do really reasonably well for the most part. It all depends on how severe or how high the urea nitrogen is and how quickly you drop it. But typical acute symptoms are headache, restlessness. Some people can have nausea, vomiting, hypertension. But severely affected patients can develop blurred vision, confusion, disorientation, seizures, coma, and occasionally can be fatal. Again, not seen so much these days because of certain practices that we do, which I'll tell you in a second here. Again, typical mild symptoms, cramps, anorexia, dizziness near the end of their treatment are all part of the syndrome. So if you have a patient who has not been dialyzed in a while or a new patient, there are certain things that one needs to do. Again, most of the time it's self-limited. With severe symptoms during the actual treatment, stop the dialysis and administer hypertonic saline or mannitol. Okay, so what can one do to prevent this from occurring? So limit the first hemodialysis session to a short one, so 2 to 2.5 hours. Do a purposely inefficient dialysis, so use a co-current flow of dialysate and blood, and limit the blood flow rate to 200 to 250, and the dialysate flow rate just at twice the QB, which is around 400, and then use a small dialyzer with a urea reduction goal of 0.4. Now, you could also do sodium modeling on your dialysis machine, which means increasing the dialysate sodium. Roughly 1 millimole increase in sodium offsets the osmotic effect of 12 milligram per deciliter of urea. Another way you can do this is to administer mannitol. So mannitol offsets 8.5 to 10 millimoles of osmotic effect of urea. Again, if you have a patient in the ICU who's admitted, say, for traumatic brain injury or intracerebral hemorrhage or a mass, always consider doing continuous renal replacement therapy, not your conventional in-center dialysis. Because again, these are patients who are particularly prone to develop dialysis disequilibrium. In fact, KDIGO recommends CRRT in patients in the ICU with neurologic injury. All right, so this is our first polling question. 20 minutes after starting her treatment, a 58-year-old patient dialyzing with a catheter becomes unresponsive following the sudden onset of nausea, dyspnea, and chest tightness. The nurse notices a low blood level in the venous drip chamber with a foamy appearance. What is the diagnosis that you should consider in this situation? Okay, sounds like most of you got the answer right. So venous air embolism is fortunately, again, rare these days because of the inbuilt protections in dialysis machines, the air detectors. However, it can be fatal if you don't recognize and treat it. So it's a pure clinical diagnosis. So if you have a suspicion of air embolism, it's clinically suspected, and you confirm it with pulse oximetry or blood gas, and you start seeing foam in the bloodline, okay? And typically it occurs when you start disconnecting the caps and bloodlines with the central venous catheters. because there's a high negative pressure in that circuit, and it sucks the air into the system. And I'll also show you where in the system air can actually enter. So the symptoms due to air embolism are dependent on how much air enters the system, the speed at which it enters it, the site at which it enters it, and what the patient's position was when the air entered it. So typically when the patient is sitting and air enters into the system, guess where it goes? Air rises, right, because it's light. So it goes into the brain, and you can see right here a patient with air emboli in their cerebral blood vessels. So in the sitting position, venous emboli migrate to the cerebral circulation, and this can result in seizures and coma. Now, if your patient is supine, typically what then happens is you develop an airlock within your major pulmonary artery, causing impaired right ventricular function. And as you can see here, this is your major pulmonary artery, and a big airlock occurs there, preventing blood from going across into the pulmonary microvasculature. This results in dyspnea, cough, chest tightness, hypoxia, respiratory failure. In fact, if you put a stethoscope on the patient at that time, you'll get a churning, gurgling type of murmur, typically like a mill wheel type of gushing, gurgling sound. Okay? So if the amount of air that enters the system exceeds 50 ml, patients can develop sudden cardiac arrest. All right, so where can air enter into the system? So this is a schema of your extracorporeal circuit. Let me orient you. This is your patient with your either arterial fistula, AV fistula, or take into consideration has a CV catheter. So air can enter if your luer connection between the catheter or the bloodline is loose. And because this is pre-pump, there is a negative suction, so air can easily go in. The second place it can occur is your arterial tubing. So if there is a crack in the polymeric silicone right here, that's another area where air can enter. And now you have the blood pump. So the blood pump now all of a sudden makes this positive pressure. So a third place where air can enter is where you administer anticoagulation or saline. So I don't know how many of you have seen that sometimes, when somebody is trying to give saline, they squeeze the bag to get the saline in. It's very, very possible that you could enter or cause air to enter. Then beyond the pump, if you don't prime your dialyzer adequately, in other words, you don't knock the dialyzer, turn it upside down, you can cause air to enter through the dialyzer. So having said all of that, so you have multiple opportunities for air to get into the system, but at the end of the day, there's always this fail-safe mechanism, which is your venous air trap. And so if I were to show you your dialysis machine, they would be right there. Okay, that's your venous air trap. So what the venous air trap does is normally the blood level in the venous air trap is full. It's right till there. And so if air were to come in, it'll push that blood level down. And guess what? When it pushes the blood level down, there's an alarm here. There's a sensor that senses that blood level going down, and it immediately stops the blood pump. So it's a fail-safe mechanism, and it clamps the line. So it prevents the air going in back to the patient. So typically air embolism these days occurs due to human error, okay? Failing to clamp the venous and arterial lines is typically what causes air to get into the system. So again, not that common. So again, the management is immediately clamp both the venous and arterial blood lines, stop the blood pump if it's not already stopped because of that sensor, place the patient in the left Trendelenburg position. It's called a Durant maneuver. So it's not just Trendelenburg, but it's also to the left. So down, Trendelenburg with the head down and left lateral. And the reason for this, I'll show you why this is important. And then simultaneously start administering oxygen, depending on how ill or how acutely seriously a patient is. Patient may need intratracheal intubation. But the idea of putting this patient in this position is that you allow that air from preventing that airlock I was telling you about in the pulmonary artery. Air rises into the apex of the right ventricle and can get absorbed slowly from there. And the head end is down so that you don't cause that air to go into the cerebral circulation. Okay, so those are the reasons why this position is adopted when you suspect air embolism. In severe cases, there's also been examples of people aspirating air from the right ventricle if it's a large volume of air that enters it. And then, hyperbaric oxygen treatment is also another way of managing this condition. So again, prevention is key as always. So we want to avoid this. So always ensure the connections between your central venous catheter, arterial needle is tight. Your heparin tube connector is tight. Make sure you prime your extracorporeal circuit adequately. Use a large volume of saline to make sure you really expel all the air out of that circuit. Turn and knock on if you have a steam sterilized dialyzer, which most of us don't use these days. Start off the blood pump slowly, okay? Always start off less than 200 mLs per minute. Your venous air trap is your fail-safe. It's always there. Always make sure there is high blood level in that venous air trap, okay? Make sure your syringes are empty of air. And then again, nobody uses, or most centers don't use reused dialyzers. Again, make sure you prime and you have a dialyzer that's adequately primed. And then, of course, your equipment, dialysis equipment. Make sure each manufacturer has different conditions, but make sure all of these, according to your technical staff, is appropriately checked. All right. So the next polling question. So this is a 72-year-old male with a radiocephalic arterial venous fistula. Was started on dialysis utilizing two 16-gauge needles at a blood flow rate of 400 and a dialysate flow rate of 800 mLs per minute with a UF goal of 2.4 liters. An hour into treatment, he develops nausea and difficulty breathing with chest and back pain. The treatment is stopped, and the technician notices a kink in the post-pump arterial tube, much like this. What is the most likely diagnosis? All right, looks like all of you got this right. So hemolysis that occurs during hemodialysis can be of multiple etiologies, okay? One cause is dialysate related. So contamination with oxidizing agents like copper, zinc, nitrate, nitrite, chloramine, and then reducing agents like formaldehyde. They can cause hemolysis. Not mixing the dialysate, the powder and the water in the right concentration, so a hypoosmolar dialysate can also cause hemolysis. And finally, hyperthermia has to be in excess of 47 degrees, which again doesn't occur because most dialysis machines have a fail-safe where it alarms if your temperature goes above 39. So thankfully, not common these days. So at least the dialysate-related cause is not common. The one that is common, I shouldn't say common, but can occur is the extracorporeal circuit related. So this is due to, say, the blood pump malocclusion. Nobody much uses this, but single needle high flow dialysis, partial occlusion of the hemodialysis catheter, kinked or faulty blood tubing, and improper roller clamps. Now, you have to understand the extracorporeal circuit is a laminar flow. So the red blood cells are exposed to differential shear stress between the center of that flow and the wall of the tubing. So they can sustain differential shear pressure from minus 500 to plus 1500 and still not break. But sometimes the limits of that are really tested, and when they do break the red blood cell, that's when you typically get hemolysis. And there was a situation that occurred in multiple states. It was a multi-state outbreak where the cassette that regulates the blood pump and the roller clamps was defective, and it caused multiple episodes of hemolysis spanning multiple states. So it was a manufacturer defect that caused that. So again, it can occur if your tubing is faulty, there's a kink that is there. So again, when you squeeze that tube, that exposes that RBC to a very high positive pressure, causing it to fragment and hemolyze. One last cause of hemolysis, and this just to show you where all of those things that I just mentioned, the oxidizing reducing agents, the faulty tubing, the roller clamps. So these are all the places where hemolysis can typically occur. And then one last cause of hemolysis is patient-related. So you might have a patient who has sickle cell disease, or hereditary spherocytosis, or autoimmune hemolytic anemia. If you give that patient the right environment, i.e. that patient, say, misses dialysis for 1 to 2 times for whatever reason, and then you dialyze them, there is a possibility that the red cells, because they are susceptible to hemolysis very easily, that missing dialysis can cause hemolysis to occur. We've had a couple of patients with sickle cell disease that ended up having that hemolysis. So how does it present? It typically presents as nausea, dyspnea, chest pain, or chest tightness, abdominal back pain, chills. And if you don't recognize it early enough, it can cause severe hyperkalemia. You know why? Because when you fragment the red cells, you release all of that intracellular potassium, and it can be fatal. So some of these patients develop acute hypertension initially before they become hypotensive. Now, if you look at the blood in that tube, it lives that bright, translucent, they call it a port wine appearance of the blood. Okay? How do you confirm this is hemolysis? Immediately draw blood from the patient, spin it down with a centrifuge. One, you'll get a low hematocrit. Second, you'll get a low serum haptoglobin and an elevated LDH. Now, if you centrifuge that plasma, you'll get a pink appearance of the supernatant. That is a giveaway that the patient has had hemolysis. So it's very, very important. Again, hemolysis is relatively rare, but if it does occur, it's critical to do a systematic assessment of what might have gone wrong to cause hemolysis. So be it a defective tubing or roller clamp or whatever, there is a specific root cause analysis that needs to be done in every dialysis unit. So you have a patient suspected of having hemolysis, immediately stop the dialysis. So don't return that blood back to the patient. Why? Remember I told you hemolysis causes hyperkalemia, so you're going to send all that potassium back into the patient. So do not return the blood when you stop the dialysis. Immediately draw some blood for some tests as shown there. A methemoglobin level is important. Why? Because chloramine, I told you, is an oxidizing agent, and it can occur in the water that it's in the dialysate, and it can cause methemoglobinemia. Not that it occurs commonly, but it's important to send that off. Next thing is immediately stabilize your patient, oxygen, hemodynamic monitoring, make alternative arrangements for dialysis if necessary. Immediately sequester that machine, that hemodialysis machine, save all of the tubing, the needles that go with it. Make sure your machine dialysate temperature control is working, and also make sure your dialysate concentration osmolality is correct. Again, we talked about sequestering it. Also, look for other patients that have had similar type of hemolysis that may have occurred. And this basically completes that root cause analysis because it's a sentinel event if it occurs in the dialysis unit. All right, the next polling question. Which of the following should be done prior to starting a patient's dialysis treatment? The access should be taped securely. The access should be uncovered. The bloodline should be looped loosely. The patient should be assessed for risk of VND. Oh, okay, well, all of you got it right. Okay, so venous needle dislodgement may sound innocuous, but it really isn't. It's an example of class 4 hemorrhage, losing more than 40% of your blood volume. So just imagine this. If a needle gets dislodged in an average sized man, he can lose more than 50% of his blood volume in less than 7.5 minutes. And an average sized woman can lose more than 40% of their blood volume in less than 5 minutes. So really very important. And typically this occurs 200 times a day in the United States. And there's 1 death every week from venous needle dislodgement. Okay? And so, again, things that one can do: improper taping of the access to the skin, okay? A loose luer lock tubing, blood lines not being looped loosely, the lines being anchored to the chair or bed and not to the patient. Always make sure the access site is visible. I'm sure a lot of your patients have their blankets or other clothing covering their access. You want to be able to see that all the time, okay? And then finally, never set those alarm windows on your pressure monitoring to be very wide. Keep that as narrow as possible, the venous pressure monitors. There are certain patient factors that needs to be taken into account. So typically, cognitively impaired patients, somebody who is restless, agitated, uncooperative, trying to pull their needles, okay? Those are the types of patients that are at high risk. Keep them as close to the nurse's station as possible, okay? Other patients like, patients with skin conditions, allergy to patches, eczema, and then again, patients who have frequent blood pressure changes or muscle cramps. These are all patients who are likely or could develop venous needle dislodgement. So what can one do to help I would say, prevent this from occurring? So there are, believe it or not, a couple of devices that one can actually use. There is an optical sensor called RedSense. Has any of you heard of that? It costs about $550. So if your dialysis unit doesn't have it, it's because probably it's expensive. But it is connected to the needle, basically there. It has a sensor that's connected to the needle, and the alarm reacts to the first drop of blood outside that system with an audible alarm, and a flashing red lamp lights up right here on the alarm unit, okay? The other thing that the Fresenius people have used, this is not showing up. There's a wireless wetness detector. That's a disposable unit that can also be used. It's connected with the 2008K home hemodialysis machine, and in some in-center patients as well, you could use that. And then there's, of course, enuresis pads that, just senses the moisture and immediately, sends off an alarm. And then for venous catheters, there's something called the hemoclip, so that prevents this from getting disconnected. So there's a clip that prevents that disconnection from occurring. Again, don't forget, the lower limit of the venous pressure alarm should be set as close to the actual venous pressure. All right, so the next situation that could occur is uncommon, but it's a potentially fatal complication. So this is the vascular access hemorrhage. And most of it, unfortunately, occurs outside the dialysis facility. In fact, 80% of it occurs outside. There was one study where 88 deaths occurred between 2000 to 2007 in 58 dialysis units. This was a study that was done. The VA, the Veterans Administration, said this is a very common cause of bleeding in their situation. But when it does occur, it's very important that you educate your patient and your patient's caregiver. So why does this occur? Because pseudoaneurysms occur from, repeated cannulation of their fistulas. And as you know, a pseudoaneurysm is not really an aneurysm. It doesn't have all the layers of the vein. It's rather composed of hematoma and fibrous tissue. And so it doesn't take much for that eventually to sort of rupture. So as I had said, the way you educate your patient and your patient's caregiver, is finger pressure over that site of bleeding. Don't try to use a tourniquet. Don't try to use a blood pressure cuff. Just get a finger over that and get them immediate help, medical help. That's the way you, prevent an unfortunate fatality. All right, so let's show you some pictures of cases where vascular access hemorrhage could be imminent. I don't know how many of you have patients that may have had their fistula with a pseudoaneurysm looking like this. See that shiny, translucent skin? Well, this is a pseudoaneurysm that's imminent of rupturing. So if you see this in any of your patients, that patient needs to see a vascular surgeon or access surgeon immediately, okay? The other situations that can occur are any type of ulcerations, thinning of their skin, infections, sloughing off of the skin over the top. So this is a severe case of an ulcer over their fistula. This one you can see it's already started to spew some blood right there. And this was right at the OR. So when the surgeon just started draping everything, you can see the squirt of arterial blood from that fistula. All right, the next polling question. So this is a 68-year-old new diabetic ESRD patient. She begins her first dialysis session utilizing a Fresenius 160 dialyzer. She has a penicillin allergy and normally takes lisinopril and amlodipine for blood pressure control. About 20 minutes into her treatment, she becomes hypotensive with systolic blood pressure in the 70s associated with dyspnea and pre-syncope. She's noted to have wheezes on lung exam. What is the likely cause of her symptoms? So read the script carefully. She has a penicillin allergy, normally takes lisinopril. She's dialyzed with an F160. The reaction occurred about 20 minutes into her treatment. Okay, so this is a type B dialyzer reaction. I'll show you why. So allergic reactions that occur in dialysis can be because of the medications we administer, typically heparin, blood products, IV iron, not so much with the type of irons we use these days, antibiotics. They could be anaphylactoid, heparin-induced thrombocytopenia. But otherwise, you can also see them with certain dialysis membranes, okay? So the bioincompatible membranes, the cellulose dialysers used to be very common with those dialysers. You get a type B reaction. With the biocompatible dialysers, the polysulfone. So in our patient, she was dialysed with an F160, which is a polysulfone. So technically, that's a biocompatible dialyser. So, but under the right circumstance. So polysulfone can interact with a patient on an ACE inhibitor. So ACE inhibitor, as you know, blocks bradykinin degradation. It's a kinase that prevents breakdown of bradykinin. So under the right circumstance, I'm not saying it occurs with every single patient, but your polysulfone dialyzer, if a patient is on ACE inhibitor and a history of penicillin allergy, be careful that if they do have that reaction, they can get up a type B reaction. The key there in that question was when it occurred. It's 20 minutes into the dialysis treatment. So type A reactions occur immediately. So it's usually within 5 to 20 minutes, whereas our patient didn't start till about 30 minutes into her treatment, okay? Type A reactions are exceedingly uncommon these days. It occur about 4 out of 100,000, whereas type B reactions can still occur. In fact, they do still occur. This case that I gave you occurred in our dialysis unit about 2 years ago, and I'll tell you how we took care of that. The type A reactions are typically due to leachable sterilant, like ethylene oxide, which nowadays dialyzers are not sterilized with. And they can also occur with the AN69 membrane because AN69 membrane activates Hageman factor, which also can cause prevent bradykinin breakdown. It's typically an IgE or bradykinin mediated reaction, whereas type B reactions are complement mediated. They use the alternative complement pathway. So many of you may know the first use reactions with any type of new dialyzer, well, that's a type B reaction. The symptoms are pretty significant or severe in a type A reaction. They have, chills, pruritus, they start, itching, urticaria, they have stridor, bronchospasm. Whereas the symptoms with the type B are less intense. I mean, they may look scary, but they're typically not as severe as type A, and they usually disappear or lessen dramatically as you continue the dialysis, okay? Typically, patients at risk for type A are ones who also have underlying eosinophilia or underlying atopy, whereas with type B, there's no particular predisposition. So, and like I said, this is the cellulose dialyzer. Nowadays, with the modified cellulose dialyzer or the biocompatible, not so common. So how do you treat it? Type A reactions do not return the blood because it's a very severe allergic reaction. You don't want to propagate the allergy, the reaction. Type B typically is just supportive treatment. So if your patient's blood pressure drops, you can give them a bolus of fluid, you can give them some Benadryl, just a symptomatic supportive treatment. This one here is, may require use of steroids, epinephrine, bronchodilators, depending on the severity of the reaction. Preventing type A reactions, again, not much occurrence these days, but typically in the past, if you prime your dialyzer adequately with sufficient saline to get rid of that ethylene oxide, nowadays, we use steam sterilized or gamma sterilized dialyzers. We don't use the ETO sterilized dialyzers. And sometimes you can also give them preemptive antihistamine steroid in those predisposed. In type B reactions, just use a different dialyzer. So if they get a reaction, switch their dialyzer, use from a cellulose to a modified cellulose. So what we did with our patient is, one, we stopped her ACE inhibitor and switched her to an ARB. But then the next treatment, she still had that reaction. So at that point, we switched her from polysulfone to Revaclear. So that's what happened in our patients. Again, they say reuse of dialyzers prevents type B, but I don't know many dialysis centers that actually, or dialysis facilities that use reuse much anymore. So, but again, remember, type B reactions, polysulfone, ACE inhibitors. All right, the last polling question. As you are rounding in the outpatient dialysis unit, you note several patients experiencing rigors. All of these patients have either a fistula or a graft as their dialysis access. You order a CBC, differential, and blood cultures. What additional steps in management should you perform? And you all of them got right. Okay, so the last situation that can occur is pyrogen reaction. So let me sort of put this in perspective for you. So you have your average non-dialysis patient who drinks approximately, 1.4 liters, 14 liters per week, about roughly 2 liters per day. Well, guess what? Your hemodialysis patient is exposed to approximately 360 liters per week. So this is just to give you a pictorial, a visual impression of the amount of exposure to weekly water. Your patient, non-dialysis patient, has a functioning kidney, is able to excrete the toxins in the urine. However, your dialysis patient is unable to excrete the toxins in the urine. The non-dialysis patient, the contaminants are selectively absorbed in the GI tract, indirectly exposed to blood, while your dialysis patient, the contaminants are always directly exposed to the blood, right, via the dialyzer membrane. So you can see why pyrogen reactions occur very commonly in dialysis patients. Well, there are several other contaminants that in the water that we use for dialysate preparation that can cause reactions. I just bring up one, which is due to microbial contamination causing pyrogen reactions. But as you can see here, you can have a whole host of other chemicals. So if your water quality that you use to make your dialysate is not ultra pure, and again, not so common these days, but can occur, you can get reactions related to that. So and these are some of the ways that you can get a pyrogen reaction. So these are actually been outbreaks that have been reported. So inadequate concentration of dialyzer disinfectant. So I don't know if you know this, but at the end of the day, when all of your dialysis is done, your technical staff in your dialysis facility does a loop disinfection of the system. So this is to prevent this from occurring. So when you don't have inadequate concentration of dialyzer disinfectant, that can cause a pyrogen reaction. Similarly, inadequate disinfection of water distribution system, like I was just saying, can also lead to pyrogen reaction. The other way is your city water, is basically not disinfected appropriately. And then lastly, there's something called the waste handling option on your machine that gets rid of the prime that you prime your dialyzer with. That can cause backflow and cause bacterial contamination of your dialysis machine. So these are just some of the ways that you could get a pyrogen reaction. So if you haven't already, I would highly encourage all of you to visit your dialysis water treatment system in your dialysis unit. Just to show you, there are basically 4-5 components. You have the feed water coming in from the city that goes into this pressure tank, then goes through a series of carbon tanks to get rid of all of these impurities that I was just telling you. The two key ones here is the RO, the reverse osmosis, which is the hydrostatic pressure that pushes those tiny impurities to prevent that impurities from going across that semi-permeable membrane, and a deionizer that removes the unwanted ions. It replaces the unwanted ions with hydrogen and hydroxyl ions. So those are two critical components of the water purification system. And then finally, you have this UV filters at the end of the loop here at the end of the water treatment system that gets rid of any bacteria that may have escaped the initial part of the system. So you can see why this is so important to keep your patients from having a pyrogen reaction. And then finally, just wanted to talk about, your patient that, obviously none of us want our patients to have an arrest, but more so when it occurs in the dialysis unit. So in 2021, so roughly about 3-4 years ago, the death rate was 192 per 1,000 patient years. And the predominant cause of death was cardiovascular. 44% of death was cardiovascular, of which a majority, 28%, was arrhythmia related. Okay? So that's your sudden cardiac arrest. In fact, the definition of sudden cardiac arrest is an unexpected death that occurs within generally less than or equal to 1 hour from the onset of symptoms without obvious non-cardiac cause in a patient known to be well within the previous 24 hours. Okay? So who are the ones who are predisposed to a in-facility sudden cardiac arrest? Typically your older population, your diabetics, patients who have been recently hospitalized, and then patients dialyzing with a dialysis catheter. Okay, the study here that was done, a 48-hour mortality of 400 dialysis patients with cardiac arrest was 60%. So what are some of the things so typically sudden cardiac arrest, believe it or not, occurs on the Monday or Tuesday after their long interdialytic interval. It's during that first dialysis day. So the reason for that is, as you can see, obvious, the long interdialytic period, so, volume. Dialysis patients by itself have inflamed, typically. We have an older group of patients who are on dialysis, the presence of uremia. There may be certain genetic factors that are important. Autonomic imbalance, sympathetic overactivity. Many of our patients have overactivity of their sympathetic nervous system. And, as you know, many of our patients, believe it or not, even though they may not overtly manifest, have underlying cardiovascular disease. So they have a high QT dispersion. QT dispersion is the difference between the longest and the shortest QT interval. And if you have a long QT dispersion, that predisposes them to heightened arrhythmias or a higher predisposition arrhythmias. And then finally, combine that with rapid electrolyte shifts, and you have a perfect recipe for sudden cardiac death in dialysis patients. So these are some of the symptoms that are typically precede cardiac arrest. Some shortness of breath, just kind of feeling sick or bad, nausea, chest pain, dizzy. Very non-specific symptoms, really. Anybody, I'm sure many of the patients tell you this, but there are no specific giveaways or symptoms that tell you that somebody is going to develop that. So what can you do? So one is reducing the progression of cardiomyopathy, right? So if your patient has systolic heart dysfunction, always assess their left ventricular systolic and diastolic function within 3 months of dialysis initiation and every 3 years thereafter. If they have diastolic heart dysfunction, use carvedilol in patients with dilated cardiomyopathy, ACE or ARBs for diastolic dysfunction, and then consider frequent dialysis to reduce their left ventricular mass. So for an echo, their concentric left ventricular hypertrophy, I know you may not get paid for doing that extra treatment, But that's what's typically recommended. Either they are signing off or not getting their full treatment, but typically what predisposes to that enlarged left ventricular mass is infrequent dialysis. The other thing is minimize dialysis-related arrhythmic triggers. Low potassium baths, it's a no-no. Avoid low potassium baths, low calcium baths, okay? So it's very important because these lend themselves to QT dispersion. Rapid ultrafiltration. So there's a reason why some of your dialysis units sort of balk when you put your UF rate at 4, 5, 6 kilograms because your patient brought in that much intradialytic, because removing a large volume in a short period of time can cause myocardial stunning. So always, if you have to, extend the dialysis time if possible, but do not try to remove a bunch. That's why they say 13 mLs per kilogram per hour, is what they would recommend. But I know a lot of your patients abuse that privilege. They, bring in a lot of volume. So education, education, education. Finally, ICDs are only been studied in ESRD patients for secondary prevention. They have not been studied for primary prevention, and bradyarrhythmias are common in dialysis patients. And so pacemakers are an option if you do have a bradyarrhythmia. And this is just a schema just to tell you what I just told you, show you what I just told you. That's my last slide.
The first one was, is there a greater incidence of hemodialysis emergencies in the inpatient setting than outpatient?
Well, it all depends on who sets up the inpatient setting in terms of, is it the same biomedical staff that are responsible for your outpatient? So it can occur in either setting. It's not unique to one or the other. But again, all of your checklists should be marked off. And it can occur in either setting. So there's no difference in setting.
Thank you. And the next question is, how long would you perform CRRT inpatient with intracranial pathology? What would be an indicator to transition to IHD if ongoing treatment is still required?
So CRRT is prolonged, right? So anywhere from 18 to 24 hours, and it all depends on the stability of the patient. If the patient continues to require ICU care, I would suggest continuing CRRT till such time that the patient is in the ICU. If the patient is stable enough to be transferred to the floor, then at that point, I think you can transition over to to conventional dialysis.
Okay. And when you are concerned for air embolus, how long do you leave the patient in left lateral Trendelenburg?
Till the patient is stable, the oxygen levels are good, and basically just till the patient is stabilized. The patient can talk to you, not still comatose, is awake.
And what can you do to initiate dialysis in an outpatient setting? Because with low efficiency HD, is it daily? How do you escalate the treatment?
So typically in a new dialysis patient or for patients who have not dialyzed in a while, typically the way I do this is start off as a co-current dialysis, use a blood flow rate of somewhere between 250 to 300, dialysate flow rate of 600, and dialyze them for about 2.5 to 3 hours. And then the next dialysis treatment, I would go up just a little bit more. So from 300 to 325, and your time from 3 hours to 3 hours, 15 minutes. And then the third dialysis treatment, I would go just a little. So I would use 3 dialysis treatments before you get to your final prescription.
And how do you recommend testing pre-dialysis HD potassium Would diabetic patients require increased monitoring?
How would you, I'm sorry, repeat that?
How often do you recommend testing pre-HD potassium? Would diabetic patients require increased monitoring?
No, I don't think so. So in the inpatient setting, obviously many of these patients get labs done every day. So you have your potassium, but I don't know that diabetes necessarily lends itself to more frequent potassium testing. So potassium, as you know, can occur, hyperkalemia can occur in anybody, not just diabetics. So the key there is your dietitian. If you know a particular patient is having hyperkalemia on labs, I would really try to narrow down what the cause of that hyperkalemia is. But avoid using 2K baths if at all possible. You can use Lokelma or one of the potassium binders on non-dialysis days to keep their potassium controlled.
And that actually lends itself to answer the next question, which was if the potassium is high, say 5.7, do you use a 2 or 3K bath?
I would use a 2K bath, but if you're still concerned, you could give the patient Lokelma or Veltassa to use on non-dialysis days.
If extra treatment days for LVH, LV overload is not an option, would having longer HD times, like 5 hours, be beneficial?
Yes, absolutely.
Is less than 13 milliliters per kilogram per hour sufficient for UFR? I've heard some support for less than 10.
No, I don't know that it's practically feasible to do 10. I mean, if your patient is that compliant and is able to really, keep their fluid rationed, I think you can do it. I have a hard time even to get to 13, much less, so I would still submit to 13. But again, you have to be very selective about this. There are some patients, even though the nurses know not to do more than 13, in an occasional patient, I said, let's, amend the rule here. Let's go up just to get him. Because if he does this at the beginning of your week on Monday, he brings in like 7 kilos, right? You're still catching up at the end of the week, not getting them to their dry weight. So you almost have to tinker with their prescription where you get some more extra fluid off in the first 2 treatments so that when the weekend or before the weekend arrives, you have not much left.
Very true. How does a catheter cause increased risk of SCD?
Oh, that was just a association where they found that if you had a catheter as opposed to a graft or a fistula, you had more likelihood. I don't know there's a specific reason why catheters lend themselves to SCD.
And why is bradycardia common and how do you treat it?
Bradyarrhythmias, you mean?
Well, it says bradycardia, but...
Yeah, so bradyarrhythmias are just typically more common in dialysis patients. So, giving them a beta blocker, carvedilol, as I'd mentioned, is a good option. Carvedilol doesn't cause as much bradycardia, but I mean, it's typically you want to make sure your patient doesn't have like sick sinus syndrome, and making sure that they see a cardiologist and make sure they're not in need of a pacemaker, basically. So.
And many of the symptoms are similar: chest, back pain, hypotension. In these complications, what are the triggers to consider these complications versus side effect of UF?
That's a good question. Again, many of these symptoms are very non-specific. So depending on the scenario in which you see those symptoms, you'd have to address it. I don't know there's one cookie cutter approach to knowing that, if you have chest pain, back pain, hypotension occurring, that it's not due to one or the other. So you just have to be vigilant, see what your patient has. The type of situation basically dictates what you do.
And last question, are you okay with potassium running high chronically in dialysis patients, like a patient with baseline mid-5s? So I guess like 5.5.
Dialyzing them with what? Which bath?
It doesn't say.
Okay.
Just
So,
are you okay?
yeah, I'm okay. I mean, obviously, they have to be dialyzed, but I would not use a 3K bath. I would still use the 2K bath for patients with a potassium of 5 or in the 5s.
Very good. Well, thank you so much. Don't forget